Good afternoon, everyone. We'd like to welcome you all to a follow-up in our series of neurology lectures, which is taken by the neurology department. Today, I have the privilege and honor to introduce one of our neurology consultants, Dr. Arun Matemani. Sir is an associate professor in neurology. He was also, I had the honor of being one of my teachers, and I was going through the posting. And today, he's going to teach us about an approach to muscle disease. Over to you, sir.
Thanks, Rohan. At the outset, I would like to thank head of medicine, Dr. Tambu, and head of neurology, Dr. Sanjit, for giving me this opportunity. So today our session is approach to muscle diseases. So we will be dealing with this. So first, we will see what are the goals of approaching when we see a patient with a suspected myopathy. And then we will be coming to, there are 10 patterns of muscle diseases. So we will go through each pattern and see some case scenarios. Right, so let's get started. So the first goal in when we see a patient with suspected myopathy, muscle disease, is to differentiate it from other diseases of the lower motor neuron. So you would have had lectures on motor neuron disease, and you will have a lecture, you had lecture on neuropathies. So initial step, so the first goal in a patient with a suspected muscle disease is to determine the correct site of localization. And this can be distinguished by the characteristic clinical and laboratory features. So the next step, once we identify the localization of muscle, next step is to identify where exactly the defect is. Whether it is a defect in the muscle channel, is it a defect in muscle structure, or is it a defect in muscle metabolism? This is a cartoon showing the structural proteins involved in the muscle. You can see the actin, myosin, then the various proteins. So disorders of muscle structure are known by various defects in the proteins. So you can have dystrophin protein. So defect will be known as dystrophinopathies. You can have dysferlin protein. Defect will be known as dysferlinopathies, and so on. The second goal is to determine the cause of the myopathy. So causes can be various hereditary disorders like muscular dystrophies, myotonias, or is it an acquired neuropathy, acquired myopathy like inflammatory, toxic myopathies, etc. Now, the final third goal is to determine whether a specific treatment is available. Most of the, apart from inflammatory myopathies, most will not have a specific treatment. So if we are not able to offer a specific treatment, then we have to strive to optimally manage the patient's symptoms so as to maximize his or her functional abilities to enhance the quality of life. So this will require a multidisciplinary approach. So we have a neuromuscular clinic here with a multidisciplinary neurology, PMR, and genetics. So coming to clinical evaluation. So this is the proper clinical approach. So most important element is to obtain a thorough history. So after history, we should have a preliminary determination of the cause of myopathy. Then we have to move on to physical examination, in particular the distribution of weakness, which should provide additional information in determining the correct diagnosis. Then the last will be the laboratory studies, blood test, EMG, muscle MRI, neuromuscular ultrasound, genetic studies. They play a confirmatory diagnostic role. So coming to history. So in the history of history taking in muscle diseases, we have basically six key questions to ask. So first question is, which negative and or positive symptoms does the patient demonstrate? So in a case of muscle disorders, as such can present with negative symptoms or positive symptoms. Negative symptoms are weakness, fatigue or exercise intolerance, atrophy, and they can also present with positive symptoms like myalgia, cramp, contracture, myotonia, and myoglobinuria. So we have to, in each case, we have to ask for these things. So weakness is the most common negative symptom. So this is the most prominent symptom as well with which patients come to us. So proximal muscle weakness is the most common type in a myopathic disorder. So patient may give, if the lower limb proximal muscles are involved, the patient may give history of difficulty in climbing stairs, difficulty arising from low chair or toilet, or getting up from squatted position. If the upper extremities are involved, then they might say difficulty lifting objects above head, brushing hair, etc. So rarely patients can present with distal muscle weakness also. So in that case, they may present with difficulty opening jars, difficulty in turning a key, or tripping due to full drop. Now, once we have the weakness, we should ask whether the onset was symmetric or asymmetric. Well, most of the muscle disorders are symmetric. Very rare, there are very rare causes which can cause an asymmetric weakness like FSHD and inclusion body myositis. Will come to that. Also, patients can present with focal muscle weakness like focal bulbar weakness. Patient can present with isolated dysarthria, dysphagia. They can present with extraocular movements like ptosis. Then very rarely the patients can present with isolated diaphragmatic weakness alone. So that's the negative symptom of weakness. Other negative symptoms like fatigue and exercise. Fatigue is very non-specific, so we can't really rely on that. Then exercise intolerance is a symptom which we see in metabolic and metabolic myopathies, especially metabolic and mitochondrial myopathies. Right. So coming to the positive symptoms which we have to ask about myalgia, cramps, and contracture. So myalgia again is non-specific. It can be episodic in metabolic myopathies, or it can be constant muscle pain in inflammatory myopathies. Also, we can ask for muscle cramp. So cramp is a specific type of pain which can last from seconds to minutes and is usually localized to the muscle to the calves. Also, there's a specific type of pain called muscle contracture, transient contracture, which is very uncommon, which can resemble a cramp, which is provoked by exercises. And this contracture is most commonly seen in metabolic myopathies, especially the glycolytic enzyme defects. Right. So this is the table which just enumerates common disorders which present with myalgias. So commonly what we see is toxic myopathies, especially statins. Then we can have inflammatory myopathies. And disorders which present with muscle contracture are disorders with metabolic myopathies, especially the glycolytic enzyme defects. Right. So another specific feature of muscle disease is myotonia. So myotonia is caused by, basically it is impaired relaxation of muscles after a forceful voluntary contraction, and it is caused by repetitive depolarization of the muscle membrane. So it commonly affects the eyelids and hands. So patients may present with muscle stiffness or tightness. Example, they have difficulty in releasing their hand grip after they shake hands, or difficulty in unscrewing a bottle top, or difficulty in opening their eyelids if they forcefully shut their eyes. So this is a specific symptom which we should try and elicit, which points to a muscle localization. So various factors can trigger myotonia, like cold, fasting, potassium-rich food. And classically, this myotonia symptom improves with repeated exercise. However, if it worsens with repeated exercises, it's called paramyotonia or paradoxic myotonia. Right. So this is a picture of a patient with an eyelid myotonia. He is forcibly closed his eyes and he has difficulty in opening after that. Tongue myotonia and finger myotonia. After finger grip, the patient has difficulty in opening his fist. So myotonic disorders with myotonia can be dystrophic myotonias or non-dystrophic myotonias. Dystrophic myotonias will have associated muscle weakness, especially myotonic dystrophy. Non-dystrophic myotonias is what we have, what is common: myotonia congenita, chloride channel defects, paramyotonia due to sodium channel defects, etc. So another symptom which we have to ask is myoglobinuria. So in a patient with any patient with this exercise induced weakness and myalgias, so we should ask if their urine has ever turned cola color or red after these episodes. So recurrent episodes, single episode may be seen after any prolonged or intensive exercises. So if patients have recurrent episodes of myoglobinuria, it is a pointer to an underlying metabolic myopathy. So metabolic like glycogen storage or lipid storage. Right. So second question. Among the 6 questions, the second question we have to ask is what is the temporal evolution? So at what age did the problem begin? So we have a different set of causes. So based on age of onset, some disorders, if the myopathy starts at birth, we can think of congenital myopathies, congenital muscular dystrophies, myopathies presenting in childhood. The separate causes, most common will be your Duchenne muscular dystrophy. Myopathies presenting in adulthood will have a separate set of differentials. So age of onset is very important to elicit. Now, what is the duration and evolution? So some myopathies have constant weakness, like inflammatory myopathies, muscular dystrophies. Some myopathies will have only episodic periods of weakness with a normal strength interictally, like metabolic myopathies and periodic paralysis. So that we should elicit. And also we should see if the patient has a constant weakness, we should ask what is the tempo of the disorder. So whether it came acute or subacutely, like in inflammatory myopathies or toxic myopathies, or is it a chronic slow progression over years, as we see in most muscular dystrophies, or is it a non-progressive weakness with little change over decades, like we see in congenital myopathies. So both constant and episodic can have muscle disorders can have monophase symptoms which are monophasic or a relapsing. So patients with periodic paralysis and metabolic myopathies, we classically see they have recurrent attacks of weakness over many years. So the third question that we have to ask is there a family history of a myopathic disorder? So for that, we have to have a detailed family tree, 3 generations that we have to make. So we have to look, is there any other involved family member? And if it is there, then we have to see whether it is dominant, recessive, or an X-linked pattern. We should ask for consanguinity. Or direct question like, does anybody in the family have muscle disease may not sometimes yield. So we have to ask whether any family members use canes, wheelchairs, do they have any skeletal deformities, or do they have any functional limitations? So these kind of questions may be more, may need more information. Now, the next question we have to ask is, are there any precipitating factors that trigger the episodic weakness or myotonia? Right. So these, so various triggers can be there. So some drugs, there are drugs which can precipitate muscle weakness, like statins. So if we see that exercise is precipitating weakness, especially during or immediately after exercise, there is a clue for a metabolic myopathy, especially the glycolytic pathway defect. If the weakness comes after prolonged exercise, then we have to think of a fatty acid defect. And if it comes after exercise followed by a period of rest or after a high carbohydrate meal, then we can think of a periodic paralysis. If fever is precipitating weakness, so we can think of fatty acid defects like carnitine palmitoyl transferase. And if cold exposure is precipitating weakness, we can think of a myotonia. Right. So this is the table showing various drugs and toxins which can precipitate a muscle disease. Now, the fifth question we have to ask is, are there any associated systemic symptoms or signs? So, muscle disorders commonly are associated with cardiac dysfunction. That we have to ask, is there any features of cardiac illness? Some myopathies, as we said, some disorders can present with diaphragm involvement. So they can present with respiratory failure as the first symptom, like in Pompe's disease or acid maltase deficiency. Right. Also, some myopathies, especially the metabolic myopathies, can have hepatomegaly. So we have to look at this. So cardiac symptoms can be in the form of arrhythmias, like in channelopathies like Anderson-Tawil syndrome, Kearns-Sayre syndrome, and some can present with congestive heart failure like acid maltase deficiency, carnitine deficiency, various muscular dystrophies like Duchenne dystrophy, Becker dystrophy, etc. And as discussed, some myopathies can present with respiratory insufficiency, while like Pompe's disease, while respiratory insufficiency can develop during the course of most muscular dystrophies. Right. So, so this is the history. So we have to ask the key questions. Then examination. So examination is also important. So, so we have to have a good general examination. Cataracts. So we have to look for cataracts or any frontal balding, which can be seen in myotonic dystrophy. Whether any dysmorphic features are there, like in congenital myopathies. Is the patient having any rash? As in dermatomycete, you might be familiar with the rashes in various inflammatory myopathies. Then is there any evidence of any diffuse systemic disease like amyloid, sarcoid, etc.? So this is the first picture is a patient with frontal balding and little bit of ptosis. So this is a classic picture what you see in myotonic dystrophy. And the second picture what you see is the typical facial appearance in a condition called Anderson-Tawil syndrome. They have low set ears and a small chin. Also, we have to look at contracture. So muscle disorders, because of the differential weakness in the muscle groups, they tend to develop contractures. All muscle disorders, most of the muscle disorders tend to develop contractures late. However, there are some conditions where you can get early contractures. So early contractures at ankle can be seen in calpain. At elbow and ankles can be seen in calpainopathies. So contractures at the intervertebral joints can be seen in laminopathies, which can lead to a rigid spine, and contractures involving the proximal and distal joints out of proportion to weakness can be seen in collagenopathies like the Bethlehem myopathy. So we have to look for contractures, especially elbow contractures and ankle contractures. Then what we can come to the proper muscle examination. So muscle examination, we can start with inspection, palpation, and then the muscle strength examination. So while inspecting and palpating, we should look for, is there any evidence of atrophy or hypertrophy? Now, atrophy in most common chronic myopathies, you can get some atrophy. Now, if we see hypertrophy, true hypertrophy, this is seen in few conditions like myotonia congenita, amyloidosis, sarcoidosis, etc. And more common is pseudohypertrophy, where the muscle bulk will be big, but the muscle will be weak. This is called pseudohypertrophy, and this we see commonly in Duchenne or Becker dystrophy. Now, an important pointer is selectivity of muscle involvement. So selective, what we say, selective muscle involvement. So it is characteristic of genetic muscle disorders or muscular dystrophies. So they tend to weaken certain muscle groups but leave the other groups unaffected. Also, they may involve even in a single muscle, it involve a part of the muscle while leaving the other part not involved. So that is hypertrophy and atrophy within the same muscle. So this is called selectivity. So we have to actively look at selectivity of muscle involvement. So this is a pointer to the genetic nature of myopathy. So this selectivity is it becomes prominent. Various signs are clinical signs are there. So first picture, what you see is something called valley sign. Valley sign is seen in DMD. So you see a hypertrophic infraspinatus and the posterior fibers or deltoid are atrophied. So the selectivity of muscle involvement. So valley sign is seen in Duchenne muscular dystrophy. The second picture you see, you have to use a little imagination. So this is called calf heads on trophy sign. So calf head on trophy sign is seen in dysparlinopathy. Now scapular winging. So we have to elicit this sign in suspected muscle disorders. Scapular winging, what is seen in commonly in many disorders, but commonly is seen in facioscapulohumeral dystrophy. We can have anterior axillary fold wasting in various myopathies. So we can have Popeye arms. That is Popeye arms is seen in facioscapulohumeral dystrophy. Biceps lump, that is part of the muscle is in the biceps muscle is atrophic while part is hypertrophic. So this is called biceps lump, which is seen in dysparlinopathy. Polyhill sign. Polyhill sign, you can see different mounts of hypertrophic and atrophic muscles. This is seen in facioscapulohumeral dystrophy. And the next one is diamond on quadriceps. That is inside the quadriceps muscle itself, some part is atrophied, some is hypertrophied. This is seen in dysparlinopathy. Calf hypertrophy is seen in Duchenne muscular dystrophy, and again wasting of calf can be seen in dysparlinopathy. So this inspection, palpation, and muscle examination can give you clues to the etiology. So after the muscle examination, so we can attempt to classify myopathic disorders into 10 distinctive patterns of muscle weakness. So each pattern will have a specific set of differentials, and final diagnosis then can be confirmed based on selective laboratory evaluation. Right. So after examination, so most common pattern we find is the proximal limb girdle weakness. So this is the most common pattern of muscle involvement. So we see symmetric weakness affecting predominantly the proximal muscles of legs and the arms, or this is also known as the limb girdle distribution. Distal muscles are usually involved, but to a very lesser extent, and can have neck extensor and flexor muscles involvement also. So this is the pattern, proximal limb girdle weakness. This is the pattern which we commonly is synonymous with a myopathy. This is what we see in most hereditary and acquired myopathies. So we'll see some case scenarios also. So let's look at case one. So a 5-year-old boy was brought by his mother to his pediatrician because of running difficulties. The mother noted that the boy was a product of normal pregnancy, but was not able to walk until 16 months of age. So there is a motor delay. His walking was late. Also, she noticed that the boy also had prominent calves. And so she volunteered history of her brother who had similar calves and had died at the age of 12 with heart complications. So 5-year-old boy with a motor delay, with prominent calves, and a family history of brother with similar calves and who died at the age of 12 with heart complications. So examination, patient's vitals, some hypertension was there, and examination revealed proximal weakness of both upper and lower extremities, or a limb girdle pattern weakness. There was calf hypertrophy, normal sensations. Gover's sign was positive, and creatinine kinase done was around 10,000. So what's the diagnosis we are seeing? This is a patient with a classic presentation of Duchenne muscular dystrophy, early onset, motor delay, and calf hypertrophy. So whenever as adult physicians, we may not be, some of you may be seeing it in peripheral places. So whenever you see high creatine kinase, motor delay, and calf hypertrophy, so we should suspect a DMD, Duchenne muscular dystrophy. So let's see another case. A 24-year-old man gave a 3-year history of progressive difficulty in raising both arms above shoulder, something he first noticed at the right side while playing cricket. Lower limb weakness also followed, resulting in walking and climbing difficulties. On examination, there was scapular winging, weakness of shoulder, again a proximal limb girdle weakness. There was an exaggerated lumbar lordosis and viscerotosis. Viscerotosis is the abdominal muscle being weak and the viscera coming. So CK was around 4,000. What's the diagnosis? So this is a patient with a calpainopathy, proximal limb girdle weakness, exaggerated lumbar lordosis, viscerotosis. So we have to suspect calpainopathy. Let's see another case. 21-year-old woman, young woman, presented with weakness. Her motor development was normal as a child. In primary school, she was actually faster and stronger than other children. Now, so at 15 years of age, she noticed that when she ran, she just could not go. And over the ensuing 6 years, her leg weakness slowly progressed. Now, since the last 16 years, she recalls she could not stand on her tiptoes. That difficulty in that will be difficulty in weakness of her gastrocnemius. So could not stand on her tiptoes. Her arms remain strong. There is no ocular bulbar, respiratory or cardiac symptoms. She never had history of cramps or episodes of dark urine. Now, on examination, she had diminished calf bulk, but no facial weakness or scapular winging. On lower limb examination, the power was hip flexors, hip extensors, hip adductors were 4 plus, knee extensors were 4 minus, and there was a diamond on quadriceps sign on the knee extensors, that is quadriceps. Ankle flexors, sorry, knee flexors 4 plus, dorsiflexors 5, and ankle plantar flexors were slightly weak. So we have seen previously this kind of proximal limb girdle, especially here the lower limb is more involved, and she has a diamond on quadriceps sign. So this is a case of distal limb. So the common limb girdle muscular dystrophies that we see clinically are calpainopathy, dysphalinopathy, sarcoglycanopathy, and anactaminopathies. Right. So let's see the second pattern. So the most common pattern is the proximal limb girdle. So some myopathies can present with distal weakness. So of course we have to distinguish it from peripheral neuropathies, because distal weakness is not a common presentation of myopathy. So predominantly involves the distal muscles of upper or lower extremities. The lower extremities can involve the anterior or the posterior compartment. Involvement is usually, although not invariably, symmetrical. Now, so what are the myopathies which present with distal weakness? So there is an entire distal group, distal myopathy subgroup. Can have Wielander, Nonaka, Miyoshi. Right. So if the patient has a anterior weakness, that is tibialis anterior weakness, they can present with foot drop, especially myotilnopathy, Desmin. So how can we distinguish this pattern from a peripheral neuropathy? So even though their ankle dorsiflexion, the tibialis anterior is weak, the toe extensors will be preserved. That there will be sparing of toe extensors, and we can also see hypertrophy of extensor, the muscle on the foot called extensor digitorum brevis. So this is the pointers to a muscle disease. So there can be weakness of the posterior compartment, gastrocnemius soleus, especially dysphalia, and some distal myopathies can have weakness of both the anterior and posterior compartments. Right. So let's see a case. A 25-year-old young man presented with progressive bilateral foot drop for the past 5 years. So he is also distal weakness, both legs, 5 years. He is also having hand weakness for the past 6 months. So on examination, what you find is bilateral, the tibialis, they have bilateral tibialis anterior muscles are wasted, and first dorsal interossea is also wasted, and lower extremities, this is what we find: hip flexors, hip extensors, hip abductors, adductors 4 plus. This mild weakness will be there. Knee extensions are fully preserved. Knee extension, that is quadricep, is fully spared, 5%, 5. And while knee flexors are weak, predominant weakness of ankle dorsiflexors, grade 2 power, and plantar flexors, grade 4 plus power. And CPK will be around 600. So this is a common distal myopathy, what we see clinically. It's called Nonaka myopathy. It has different names. GNE myopathy is the current name. Previously, it was known as Nonaka myopathy or HIBM, hereditary inclusion body myopathy. Right. So the third pattern that we see in muscle disorders is what called a scapuloperoneal pattern. Patients can have proximal arm and distal leg weakness. So this pattern affects the periscapular muscles of the proximal arm and the anterior compartment muscles of the distal lower leg. So scapular muscles of the upper limb and anterior compartment of the distal of the lower limb. So scapular muscle involvement usually we see as scapular winging, and this can be very asymmetric. One side can be more involved. So when we see this pattern, that is a scapuloperoneal pattern with facial weakness, it is suggestive of a disorder called facioscapulohumeral dystrophy. So other disorders in this pattern, most common is facioscapulohumeral dystrophy. Other common disorders, even acid Pompe's disease can present. Emery-Droufe dystrophy. Calpain also can have this pattern. So let's see a case. A 35-year-old man who worked as a construction worker presented for evaluation because he had been catching his toe and falling multiple times at work. That is, he is having foot drop. So he is catching his toe because of the foot drop and is falling multiple times. He stated that he has trouble lifting his left foot at his ankle. And while he was not sure when it first started, he felt it progressed fairly rapidly. He also stated that despite his work in construction, he has never been able to lift his right arm above his head. So there is some weakness of the periscapular muscles. And he has not been able to whistle. There is some weakness of the facial muscle. That no one in his family has a similar disorder. On examination, he could not bury his lashes on forced eye closure. He had a flattened pucker, and there is a scapular winging more on the right side, and he has difficulty in abducting arms above 80 degrees, and we see a beaver sign, positive beaver sign, and there is weakness of tibialis anterior, which is greater on the left than on the right, and CPK is around 500. So what is the diagnosis? So this is a classical finding in muscular dystrophy called facioscapulohumeral dystrophy. Facial muscle is involved, periscapular muscle is involved, distal leg muscles are involved, and we can most of them also have abdominal muscles. We can have a positive beaver sign. Right. So the next pattern is the distal arm and proximal leg weakness. So distal arm weakness involving the distal forearm, that is wrist and finger flexors, and proximal leg weakness involving the knee extensions. That's mainly the quadriceps. So this in this pattern, facial muscles are usually spared. So when we see this pattern, distal arm and proximal leg, and again this pattern is synonymous with inclusion body myositis. So let's see a case. A 67-year-old man presented with a 1-year history of progressive weakness of left hand grip and 6-month weakness of right hand grip. And neurological examination, there is mild weakness of bilateral elbow flexors, wrist flexors, left further than right. There is focal patchy weakness of finger flexors, especially deep finger flexors, ranging from moderate to severe. and there is mild weakness of hip flexors and knee extensors and moderate weakness of ankle dorsiflexors. So this pattern is classically seen in inclusion body muscles. Right. So coming to uncommon patterns, we'll quickly go through this. So some muscle disorders can present with ptosis with or without ophthalmoparesis. So ptosis without ophthalmoparesis, congenital myopathies. Ptosis with ophthalmoparesis will have a separate differential. Most common is oculopharyngeal muscular dystrophy. So again, this is a rare pattern, muscle disorders with prominent neck extensor weakness. Rare pattern. The next pattern is bulbar weakness. So muscle disorders with prominent bulbar weakness. What we see clinically is inflammatory myopathies. They of course will have limb-girdle pattern. Along with that, they will have a prominent bulbar weakness. The muscular dystrophies which have a prominent bulbar weakness is oculopharyngeal muscular dystrophy. And as far as inflammatory myopathies are concerned, all of you will be well versed. The various muscles myositis specific antibodies in dermatomyositis, synthetase syndrome, necrotizing myopathy, and the multisystem involvement and the treatment. So only inflammatory myopathies we can offer a definitive treatment, steroid sparing agents. Right. So there are a couple more patterns. So episodic, this pattern will be episodic pain, weakness, and myoglobinuria related to exercise. So exercise precipitating weakness, pain, and myoglobinuria. So when we have this pattern, we have to think of metabolic myopathies, glycogen storage or lipid storage. So metabolic myopathies which present in adulthood can be glycogen storage, Pompey's disorder, fatty acid oxidation defects like carnitine palmitoyl transferase deficiency, mitochondrial disorders. So these are the key points which point to a metabolic myopathy, myoglobinuria, exercise intolerance, fatigue, symptoms arising after a period of fasting, prominent myalgia, cramps. You can have transient contractures or fixed contractures. Right. So symptoms are precipitated by short bursts of high intensity exertion, then we should consider glycogen storage disorders. Some of these may have a second wind. That is, there will be resolution of pain and regaining of muscle strength after resting for around 10 minutes, at which point further exertion can take place without symptoms. So second wind phenomenon is typically seen in McArdle's disease. While symptoms which are preceded by prolonged periods of low intensity exercise is typical of fatty acid oxidation disorders, also mitochondrial myopathies. So short bursts, short exercises, high intensity exercise precipitating symptom is glycogen storage. Prolonged low intensity exercises precipitating weakness is fatty acid oxidation defects, also mitochondrial myopathies. So let's see a case. A 25-year-old male was referred to a neuromuscular service after presenting with type 2 respiratory failure. He had 3 months history of increased tiredness, drowsiness, and had been found to be hypoxic with marked hypercapnia with an elevated serum creatine kinase. On further questioning, he reported delayed motor milestones as a child and that he struggled with sports. He was initially thought to have polymyositis and treated with corticosteroids. So he presented with a type 2 failure and his respiratory state improved with the BiPAP. And on examination, he had marked paraspinal and scapular winging with hamstring and calf and anterior leg wasting. So what is the diagnosis? This is a patient with Pompey's disease. Let's look at another case. Woman aged 26 years was referred to a neuromuscular clinic after an episode of rhabdomyolysis, which was triggered by exercise. with the initial serum CPK creatine kinase of 59,000. And she says that in retrospect, she has been having exercise-induced myalgia and myoglobinuria for a few years, despite being very fit and active. And she says that her myalgia tends to happen 40 to 120 minutes into exercise and then would persist for days afterwards. And there is no second wind phenomenon. And examination was normal. So in this, we should suspect fatty acid oxidation. So this is the cartoon showing the both the glycolytic pathway and the fatty acid oxidation pathway. Right. So two more patterns we have to cover. So we have seen weakness, myalgia related to exercise. Now, weakness which is delayed or unrelated to exercise, we see in various periodic paralysis, calcium channelopathies, hypokalemic periodic paralysis, sodium channelopathies, hyperkalemic periodic paralysis. So let's see a case. A 29-year-old man present to the emergency department following an attack of paralysis that occurred after a football game and drinking several beers with his friends. In the emergency department, his potassium was 1.3 and CPK level was in the thousands. And his history revealed that he had experienced other attacks during adolescence that had never been diagnosed because they had always been only partially limiting and always resolved spontaneously after several hours. He has since learned to avoid high carbohydrate meals and exercise to avoid recurrence of the episodes. On examination, his muscles appear to be of normal bulk tone and only the mild scapular winging. So ECG shows features of hypokalemia, flattening of T waves, and potassium level improved after 4 hours after potassium supplementation. So this is classic of hypokalemic periodic paralysis. Now the last pattern that we have to learn is stiffness and decreased ability to relax, or myotonias. So disorders which present with myotonias. So this pattern includes all disorders that produce myotonia and paramyotonia. And these are mainly channelopathies, basically hereditary disorders involving skeletal muscle, sodium and chloride channel, as well as the dystrophic myotonias, myotonic dystrophy type 1 and 2. Right. So non-dystrophic myotonias are there, dystrophic myotonias are there. So let's see a case. A 27-year-old man presented with for evaluation of painful stiffness, and he has always been considered muscular for as long as he could remember, and people had asked whether he went to the gym. So beginning in primary school, he had noticed trouble with sports which require quick reflexes. When running races in the track, he would freeze when the starting gun would go off, even after warming up. If he overexerted himself, he would remain sore for the rest of the day. And he says that his father also was always muscular despite never working out. So this is called Herculean appearance seen in myotonia congenita. So this is a case of myotonia congenita. And the patient noticed more pain with the stiffness as he grew older. And in high school, this symptom required him to alter his choice of sports and activities. He eventually sought treatment because he was no longer able to play any sports. Examination, he had normal strength, but he had hand grip and percussion myotonia. So this is a typical case of myotonia congenita, chloride channel myotonia. Let's see another case of myotonia. A 21-year-old woman presented for evaluation of stiffness, and she first noticed that the body would freeze up at 8 years old when she swam in cold water. In addition, she noticed that in cold weather, she would become stiff and achy. And sometimes after sneezing, especially if sneezed more than once, she was unable to open her eyes. And her mother, aunt, and first cousin all had stiffness and achiness when swimming in cold pools. On examination, she had mild symmetric proximal weakness, prominent myotonia, which worsened with repetition. So this patient has paramyotonia. This is a sodium channel myopathy, paramyotonia congenita. Right. So we have covered the 10 patterns of muscle weakness. So after we make a pattern, then we have to investigate. So the available laboratory investigation in myopathy is creatine kinase. Then we have EMG, we have neuromuscular muscle MRI, neuromuscular ultrasound, muscle biopsy, and of course genetic test. So these are the laboratory evaluations that we have for evaluation. So creatine kinase is elevated in most patients with muscle disorders. In slowly progressive myopathies, however, it can be normal. And the degree of elevation can be helpful in distinguishing different types of muscular dystrophies. So if we see a CK level more than 10,000, then we have to, in an appropriate sitting, we have to suspect this muscular dystrophy, dystrophin, calpain, dysferlin. However, we should be careful that CP can also be elevated in other disorders, can be elevated in motor neuron disorders, neuropathies, and there are other factors also which cause increased muscle mass, hypothyroidism, hypoparathyroidism, medications like statins, raise sex, etc. And IM injections can also cause increased CP. So that we have to keep in mind. Right. Then we have EMG. So while we put the needle, whether we are getting abnormal fibrillations or sharp waves, if we have this, then close to inflammatory myopathies, muscular dystrophies. In myotonia, if we get myotonic discharges, then it gives more clue. So what is a myotonic discharge? So it has a characteristic sound. It's called dive bomber sound with a waxing and van. So this is the cartoon which shows the EMG appearance of a myotonia. Right. So biopsy. So final diagnosis may require muscle biopsy or a genetic study. So whenever muscle biopsy, so we have to be careful when to do muscle biopsy. So selection of appropriate muscle to biopsy is critical. So muscles that are severely weak, that is MRC grade 3 or less, should not be biopsy because the results are less likely. They are likely to show only end stage muscle disease. In addition, muscles that have been recently studied by needle EMG should be avoided because they will have artifacts created by needle insertion. So muscle biopsies should be taken from muscles which have at least grade 4 strength. So in upper extremities, so we have to most accessible muscles are biceps or deltoid, and in the lower extremities, best choice would be a vastus lateralis. Right. So that comes to the end of the lecture. Questions I can answer.